Hello, everyone. So today's topic is on cardiac arrhythmias. The learning objectives are state the AASM reporting guidelines, describe the normal ECG parameters, and understand the systematic arrhythmia analysis steps, explain the rule of differing morphology, use the algorithm for AASM reporting of cardiac arrhythmias, and understand the polysomnographic monitoring and recording techniques. So let us go through this one by one. Now the AASM technical considerations are, we use the modified lead 2, which is recommended. Additional leads may be placed if clinically indicated at the discretion of the practitioner. And the high frequency filters should be 70 Hertz and low frequency 0.3 Hertz. And the digital resolution should be 12 bits. Sampling rate desirable is 500 Hertz and minimal is 200 Hertz. And standard ECG electrodes are suggested rather than the gold cups. Now, the different lead derivation should be employed if the P wave is not clearly defined or the QRS complex is not sufficient, it does not have enough amplitude. If the muscle artifact is present, it is appropriate to lower the high frequency filter to 35 or even 15 Hertz. If slow wave artifact such as respiratory or sweat artifact is present, it is appropriate to raise the low frequency filter to as much as 1 Hertz. Now, how do you decide upon the normal and abnormal? So the AASM guidelines state that the score, how do you score sinus tachycardia and bradycardia? Sinus tachycardia during sleep for sustained heart rate greater than 90 beats per minute for adults is sinus tachycardia. So if it is more than 90, we say it is sinus tachycardia. And when do we say it is bradycardia? When the heart rate is less than 40 beats per minute during sleep. This is applicable for the ages from 6 years till the adulthood, also for the adulthood. Assistly for cardiac pauses greater than 3 seconds duration. This is also for the pediatric age of 6 years, also for the adult. Wide complex tachycardia for a rhythm lasting a minimum of 3 consecutive beats at a rate greater than 100 beats per minute with a QRS duration greater than 0.12 seconds. So wide complex tachycardia is rated when the heartbeat is more than 100 beats per minute for 3 consecutive beats. Narrow complex tachycardia for the rhythm lasting a minimum of 3 consecutive beats, again 3 consecutive beats at a rate greater than 100 beats per minute with a QRS duration less than 0.12 seconds. Now, how do we score atrial fibrillation? Atrial fibrillation, if there is an irregularly irregular, in atrial fibrillation, you have the atria fibrillating. So you have an irregular ventricular rhythm associated with the replacement of consistent P waves by rapid oscillations that vary in size, shape, and timing. So, there is a bizarre in the P wave, but QRS is normal. That's when we call it as atrial fibrillation. Significant arrhythmias such as blocks should be reported if the quality of the single ECG lead is sufficient for accurate scoring. So you see the block, type 1, type 2, or type 3 blocks, you report that. Ectopic beat should be reported if clinically significant. Some of them are considered normal. So if it is clinically significant, you report it. Now, let us go through the conduction pathway of the and the cardiac cycle. So the basic understanding of the normal conduction pathway of the heart and the interrelation of the events in the cardiac cycle is essential prior to the discussion of abnormal heart rhythm. So you have to know what is normal in the conduction pathway to know what is abnormal. Now, as you know, the basic anatomy goes this way. The same impulse starts from the SA node. That's called the SA node is called the pacemaker of the heart, right? So from the SA node, the signal travels to the AV node, then to the bundle of His, and then it diverts to the left and right bundle branches, right? Then the Purkinje system. So it starts from SA node until Purkinje system, you have the conducting pathways. So in this picture, you can see that the SA node is located here in the right atrium. Then you have the AV node, and then you have the bundle of His, and then you have right and left bundle branches, and then the Purkinje fibers. So you have the right atrium here, left atrium there, right ventricle here, and the left ventricle there. So the normal ECG waves are given here. You have the P wave, you have the PR interval, you have the QRS complex. See, look at the QRS complex. And then the T wave. So you have P, Q, R, S, T. These are the waves that denotes the electrocardiogram. So this morphology, the shape that you see here is considered normal. So give some time to look at the normal waves so that you can identify what is not normal, which is abnormal. So you have a very defined P wave, and you can see that the PR interval, it's isoelectric in the sense it's in the same line. And then you have the QRS complex. This is the QRS complex. Then you have the T wave. Now, what is the relationship between the ECG waveforms and the cardiac cycle? The anatomy of the conducting pathways and the cardiac cycle and the ECG waveform. So P wave, during P wave that you saw there, P wave, you have something called as atrial depolarization. Okay. And during QRS complex, there is ventricular depolarization. This is what happens during the P wave is formed because of the atrial depolarization, and QRS complex is formed because of the ventricular depolarization. What does a T wave caused by? T wave is caused by ventricular repolarization. So initially you have depolarization, then at T wave you have repolarization. Now PR interval, the interval between the P and the QRS complex, which is the last portion from the end of the P wave. This is the pause between atrial and ventricular depolarization. So you have atrial depolarization, then you have a pause, and then you have the ventricular depolarization. This is considered normal. So again, you can see that the P wave is caused by the atrial depolarization. Then you have the PR interval there. You can see a PR interval. And then you have the ventricular depolarization there, right? Then you have the T wave where you have the ventricular repolarization. So you have PR interval, you have the ST segment. Look at all this. This knowledge is important to see the abnormal ECG. Now, what kind of a rate is called as the normal rate? A heart rate between 60 beats per minute to 100 beats per minute is considered normal. Okay, 60 to 100 is considered normal. A PR interval of 0.12 to 0.20 seconds is considered normal. A QRS interval less than 0.12 is considered normal. SA node discharge is like when SA node is working, when the pacemaker of the heart is active, then you get a heart rate of 60 to 100 beats per minute. So if the impulses come from AV node, atrioventricular node, then you get a heart rate of 40 to 60 beats per minute. It's lower than the SA node discharge. Ventricular tissue discharge, there can be impulses from the ventricular tissue itself. So that might be again lower rate, which is 20 to 40 beats per minute. And when we say normal, the rhythm has to be regular. You have the PQRST, again you have the PQRST. So the rhythm has to be regular. It has to be as you saw in the picture. So what is a normal sinus rhythm, which is called the normal ECG? Normal ECG is termed as normal sinus rhythm because it is originated from the SA node, sinusoidal node. So P wave will be present, QRS complex will be present, PR interval would be 0.12 to 0.20, which is normal. QRS interval would be 0.04 to 0.12 seconds. And the ratio between P and the QRS would be 1:1. So for one QRS, you have one P wave, which is considered regular normal rhythm. Rate would be 60 to 100. I told you that the normal rate is 60 to 100, and rhythm would obviously be regular. Okay. So when you see a 30-second display, the normal sinus rhythm would be looking like that. And if it is a 10-second display, you get, something like what we see as normal, this is the normal sinus rhythm. So you get the P, Q, R, S, T. Now, now we saw what is a normal ECG rhythm. Now, what is abnormal? Normal rhythm is called normal sinus rhythm, right? So an abnormal rhythm is called arrhythmia, arrhythmia. Arrhythmia is A meaning there is no rhythm. Okay, so arrhythmia. An arrhythmia is present when if there is a disturbance of the impulse formation itself in the SA node, disturbance of the impulse conduction from the SA node to the AV node and to the rest of the parts of the conducting pathways. Both of the above can occur together, and the rate is too fast or too slow. It can happen. So all these can contribute to the occurrence of a arrhythmia. Now, what is the process of arrhythmia identification? How do you know that there is a abnormality? So you have to analyze the ECG rhythm. So you see the identical morphology. If there is a waveform which looks the same, it has started from the same location and taken the same pathway. Rule of differing morphology: if the waveform looks different, if it has started from the different location and taken a different pathway, or both. So these are the rules for identification. Now look at the waveform, whether the P wave is present or absent. Is the morphology of P wave is same or not? The shape itself is differing or not? Now again, QRS complex, is it present or absent? Is the morphology, the shape is same or not? It can differ, right? It can be narrow complex, it can be wide complex. Now, what is the relationship between P and QRS? There should be a P for every QRS complex. Now, QRS should be there for every P, vice versa. So it has to be there. One P has to be followed by QRS complex. So it is 1:1 relationship. Now, measure the PR interval. Is it normal, too short, or too long? Measure the QRS interval, whether it is normal, too long, or not. Now, you have to also see whether the rhythm is regular or irregular. Okay. So is the RR interval constant? So PQRS. So the 2R waves, is it regular? Here and here it is normal. So you have a very close RR interval here and a very wide RR interval, or you have wide RR intervals. So you have to see, is PP intervals constant? You have a P there, you have a P here, and the third P wave, they are together. So it's not consistent, right? So you have to see, how do you calculate the heart rate if it is not given in the ECG rhythm? So there are two methods. Times 2 method, count the number of beats in 30-second screen and multiply by 2. So you see how many beats are there in a 30-second display, and then you multiply by 2. Or times 4 method is count the number of beats in the 15-second and multiply by 4. So you get the same value, similar value. Times 6 method is count the number of beats in a 10-second and multiply by 60. So you are actually trying to calculate it for 60 seconds, 1 minute. Do not rely on the cardio tachometer on the study. So you have to see, the actual rate. This rate is usually derived from the pulse oximeter and can be inaccurate. So you have to actually see the ECG rate. Now, what are the atrial arrhythmias? So you can have the atrial arrhythmias and the ventricular arrhythmias. So you can have PACs, sinus forces, sinus bradycardia, paroxysmal tachycardias, atrial fibrillation, sinus arrhythmias, and atrial flutter. So these are the possible atrial arrhythmia which occurs from the atrium. So except for atrial fibrillation, where the P waves have been replaced by the waves of variable size, shape, and duration, and atrial flutter, where P waves are replaced by the sawtooth appearing flutter waves. So when you have atrial flutter, you have a like a saw, you sawtooth. So you would have P waves like a sawtooth, which are very much regular and very close. Atrial arrhythmias will demonstrate, in the flutter wave, atrial flutter, there will be flutter waves, and they are like a sawtooth appearance. Now we come to premature atrial contractions. Look at the ECG waveform. So you have P waves there, present. The appearance of P wave of the abnormal beat is different because it arises from a different location. That's why it's premature atrial contraction. It may not be from the pacemaker of the heart, so the location can be different. So the morphology itself is different. QRS complex is present and it is identical, so it is same. Rhythm is irregular because you have PP and RR interval which are different. So this is a 30-second display. You see it very close. When you look at the 10-second display, you can see it clearly, right? See here. So you have a P wave there, and then you have a P wave after a long time. So the rhythm is not regular. So this is called the premature atrial contraction. So when you have a premature atrial contraction, it will not give a cardiac output. Now the key features, as you saw, that aberrant P waves associated with a beat occurring earlier than expected. So that P wave occurs prematurely earlier. Note that it is more clearly visualized when spread out in a 10-second display. So it is clear to you. So this is the feature for viewing the arrhythmias clearly. The second one is sinus bradycardia. When I say sinus, it is normal, or bradycardia is just the lower rate of the heart rate. So, but the rhythm would be normal. So P wave is present. Rate, what happened to the rate? Rate is less than 60 beats per minute, and it can be less than 40 during sleep. See, so you can see that the rate itself is too slow. So it looks like a normal sinus rhythm, except that the rate is too slow. So the bradycardia in sleep is defined as a sustained rhythm with rate less than 40 beats per minute. So if it is less than 40, then we call it as sinus bradycardia during sleep. But if it is if the person is awake, if it is less than 60 beats per minute, also we would call it as bradycardia. Now coming to atrial tachycardias, here we would have P wave, and it appears same but may not be well defined. See, supraventricular tachycardia can be there, and rhythm is obviously regular. Okay, rate is high. This is the problem here. So you would have a higher rate. That's why it is called tachycardia. So if you see the 30-second display, you can see many ECGs, and when you see the 10-second display, also you can see that it is very much close. So when you calculate the rate, it is more than 100 beats per minute. So that is atrial tachycardia. Why do we call it as atrial tachycardia? Is because there is abnormality only in the P wave. There is no problems in the QRS complex. So this is above the ventricles, which is less serious than the ventricular tachycardias. Now, sinus arrhythmias, where you have irregular features in the rhythm. So you can see that there is a rhythm is irregular, but there can be a normal morphology. So usually benign phenomenon where the heart rate increases with inhalation and slows with the exhalation. So this is sinus arrhythmia. As you see here, during inhalation, the heart, when the person inhales, takes breath, the heart rate increases and slows down with exhalation. So this is usually because of the stimulation of the vagus nerve. Okay. This can be seen in youngsters and athletic individuals. This is benign. This is not a serious problem. This can also be seen when the patient has an apnea. And then when the person starts breathing, then you get a accelerated heart rate, meaning a normal heart rate. Now, there can be sinus poses, okay? So where you have a P wave which is absent, P wave would not be there, it is absent during the pose. QRS complex would be absent, PR interval would be absent. There is a pause. There is nothing happening there. And then the the rhythm becomes irregular because of this pause. Look at that. So there is a isoelectric line where there is no waveforms. So this is called the pause, sinus pause. This is sinus, so it's normal. So, but if it is lasting for 3 seconds, you know, if the isoelectric line is lasting for 3 seconds, then we call it as asystole. There is no cardiac output. It can be due to sinus arrest or block of the sinus excitatory impulses. So this usually cannot be determined on surface ECG and requires a electrophysiological heart study. So you have to do further, investigations for this patient. Now coming to paroxysmal tachycardias, where we have P wave which is present, but it is aberrant, often hidden. You can't see it clearly. QRS complex is present. It may have a slight variation. Rhythm is regular during the paroxysmal events. Rate is higher, 150 to 250 beats per minute. So paroxysmal tachycardia, supraventricular tachycardia in 30-second display and 10-second display. You can see that there is a irregularity. So abrupt increase in the heart rate and abrupt termination of the increase in the heart rate, typically with normal appearing QRS complexes. So this abrupt onset and offset is termed as paroxysm. That's why it's called paroxysmal tachycardia. So you can see that suddenly the heart rate increases and then it slows down. Then again it increases and then slows down. So that is called paroxysmal. Okay. Now coming to the atrial fibrillation, P wave you cannot differentiate. The atria is just vibrating or fibrillating, and PR interval is not measurable. So PQRS ratio is not applicable. You can't even find out a P wave there. Ventricular rate highly variable, it changes, and rhythm is irregularly irregular. So in the beginning, I told you if the patient has atrial fibrillation, the rhythm would become irregularly irregular. See here, you can't see the clear P wave. The atria is fibrillating. So you can see that there is no defined P wave. So the key feature is that it is irregularly irregular rhythm. P waves are replaced by rapid oscillations of varying size, shape, and duration. Now, the next supraventricular tachycardia, which is occurring in the atrium, is atrial flutter. In the atrial flutter, I told you that the waveforms would look, the P wave would look like a sawtooth. Okay. And then you have a rate which is very high. Atrial rate would be very high. And the ventricular rate depends upon the degree of the block. And rhythm would be regular or irregular depending upon the variability of the block that occurs there. So look at the ECG waveform. Look at the P. You can see a well-defined sawtooth appearance. So you have many P waves. So you have distinct regular rapid flutter waves with sawtooth appearance, and ventricular rhythm can be regular or irregular. Now coming to junctional arrhythmias. So premature junctional contraction can be there, junctional rhythm can be there, accelerated junctional rhythm, and junctional tachycardia. So what are the key features of junctional arrhythmias? Junctional arrhythmias may have inverted P waves due to the retrograde conduction of the P wave, which may not be seen as it occurs in the concert with the QRS complex and it is buried, so you can't see it clearly. If the P wave is inverted, the PR interval is shorter than normal, or the P wave may even occur after the QRS complex. So this is a premature junctional contraction. So you can see that P wave is premature and abnormal configuration can be there. It will be inverted. It can be before, after, or hidden in the QRS. So you can't actually find out where is the P wave. See, it's hidden, right? Rhythm is irregular. Rate is usually normal but can occur in sinus tachycardia or sinus bradycardia. So key features are normal, appearing QRS complex, which is occurring earlier than expected, no P wave or inverted P wave. Junctional or nodal rhythm, P wave, if seen, is having abnormal configuration, will be inverted, can be before, after, or hidden in the QRS. Junctional rhythm is like that. Rhythm can be regular, but the rate would be 40 to 60 beats per minute. Now see here. So you can see the rhythm is slower than the previous ECG, right? Here, premature junctional contraction, you had, tachycardia, but here you have a slower rate. Here also the rate is not that high. So here you have a more, slower rate, and P wave is not, very much clear. So the P wave is inverted and occurs before the QRS complex with abbreviated PR interval. The rhythm is regular and the rate is within the normal range of junctional tissue, which is 640 to 60 beats per minute. Now, what is accelerated junctional rhythm for? Accelerated junctional rhythm is P wave will be inverted and can be seen before or after hidden in the QRS, like all the junctional arrhythmias. And you can see that the rhythm is regular here and rate is normal. See, but P wave cannot be visualized. This is the problem here. Junctional tachycardia again, the rate would be higher. P wave is not seen again. AV blocks. AV blocks is atrioventricular blocks is a set of another set of ECG abnormality. So you can have first degree AV block, second degree AV block, Morbitz type 1, second degree AV block, Morbitz type 2, and third degree AV block. So as we say block, there is a problem with the conduction of the electrical impulses between the atrium and the ventricles. The impulse transmission is either delayed or totally blocked. Okay, that's why we say atrioventricular block. So first degree AV block is usually considered, not a big problem if the patient is not symptomatic. You can see that in the first degree AV block, the only problem can be, you have a long PR interval, prolonged PR interval. That may be the only problem in first degree AV block. It may not be very serious. Patient may not be symptomatic also. It may be like a sinus rhythm. Now, second degree AV block, type 1, you see that normal sinus P, but some of the P wave are not followed by the QRS complex. Okay, progressively lengthening PR interval can happen, and the P QRS ratio can be more than 1:1. Rate is usually slow to normal and rhythm is irregular. So you see here that the P wave is here, and then you get a longer PR interval there, much longer there, and very long here. So this is type 1 second degree AV block. Second degree AV block type 2 is, when you have normal normal sinus P, some not followed by the QRS complex. And rate is usually slow to normal and rhythm is irregular. See here. So you have a P wave not preceding a QRS complex. So you have a left alone P wave and there is no cardiac output here. This is a problem. Non-conducted P waves. So there is a P, but it does not go to the QRS and then T. This is the Hayes phenomenon. Okay, second degree AV block type 2 is Hayes phenomenon. Third degree AV block is when you have, totally distorted P wave and QRS complex. Ventricular rate is 40 to 60 if the block is high and less than 40 if the block is lower. So you have a regular PP interval and regular RR intervals, but not the same rate. So you get totally distorted. There is no connection between P wave and QRS. So in third degree AV block, there is no very minimal cardiac output. So it's it has to be treated. It's a serious situation. So this is also known as AV dissociation. There is no connection between the AV, P wave and the QRS. Now, ventricular arrhythmias are more serious ones: premature ventricular contractions, idioventricular rhythms, accelerated ventricular rhythm, ventricular tachycardia, and ventricular fibrillation. So, ventricular arrhythmias, the main features are ventricular arrhythmias are void of P waves prior to the abnormal beat. The QRS complexes are prolonged and often bizarre in appearance. So, it is not a normal physiology. So, unifocal PVCs, premature ventricular contraction, you can see a wide QRS. See here, unifocal. So, the morphology is only one. The focus is only from one place. Multifocal PVCs, you have no different focus there. Too many PVCs. See here, one there, one. Ventricular bigeminy. So you get two PVCs together. That is called bigeminy. Trigeminy is like you get three waveforms. Okay, so you get these three waveforms in the rhythm. Ventricular couplets. Couplets are you get two waveforms together, two white QRS together. And ventricular rhythm is when you have widened, so you have PVCs, but you have in PVCs you have normal QRS as well. But here in ventricular rhythm, ventricular tachycardia, you have all white QRS complexes which are abnormal. So you just get the ventricular rhythm there. No P wave. The beats are this is a very low beat. Accelerated ventricular rhythm is when you have a little more faster rate, but abnormal QRS complex. You can see that it is white QRS. Don't you see here? You don't have a P wave and you get a white QRS. No P wave and bizarre QRS complex. Rhythm is regular. Ventricular tachycardia is almost a cardiac arrest. It's a cardiac arrest. So you don't have, you may not have pulse when the patient has a ventricular tachycardia. Pulseless and with pulse is also there. So you have to check the pulse of the patient. So here you can see that white QRS complexes are present. Sustained ventricular tachycardia again, you get all white QRS complexes, high rate. So you have to access the emergency services. This is an emergency arrhythmia. Access the patient, assess the patient, and follow your institutional emergency protocol. So you have to do the ACLS. You have to resuscitate the patient, or you call somebody who is trained to do that. Ventricular fibrillation, again, the ventricles are fibrillating, like the atria was fibrillating. Here there is no cardiac output. You can see barely any wave from there, just that you have some non-identifiable waveforms. This is called ventricular fibrillation. This is also an emergency, medical emergency. You have to resuscitate the patient. You have to call the emergency medical responses and then follow the treatment protocols. So what are the interventions? Sustained tachyarrhythmias, atrial or junctional tachycardias or ventricular tachycardias, atrial fibrillation and flutter with rapid ventricular responses and sustained ventricular arrhythmias requires immediate patient assessment and level of consciousness, dizziness or lightheadedness, presence of chest, arm or neck pain and blood pressure. So you have to assess the patient, take vital signs. In case of unresponsiveness, if the person becomes unresponsive, activate the emergency medical responses and treat the patient accordingly. Other arrhythmias like runs of ventricular tachycardia, asystole second or third degree blocks, or if the patient does not have any atrial fibrillation or flutter before, call the medical director, referring physician or house officer for direction according to the protocol. So if you don't get anyone, call the emergency medical responses immediately. Now, how do you record and monitor these? A single prescribed or mandated electrode combination may not always demonstrate a well-defined P wave or QRS complex or sufficient amplitude. So the EKG quality should be observed before or during the physiological calibration procedure. So you have to get a proper, good quality ECG waveform. So modified lead 2 derivation is recommended. Different lead combination should be sampled to provide the most adequate samples of the EKG prior to lights out. So you make sure that the patient is getting the proper ECG waveform during the calibration. And monitor the ECG waveform always. There can be augmented limb leads also. So you have to monitor if it is coming or not. Intervals are all but impossible to assess using a standard 30-second screen width. So 10 second is, you can see it very well. Measurement of the PR and QRS intervals can be accomplished by printing out the 10-second screen. So you can print the ECG and see. Standard calipers can be used to determine regularity on these printouts. If it is possible to determine intervals and test regularity by viewing the stationary 10-second window and using the index card. If you are not an expert, you have an index card, then you can measure the RR and PP interval. So to summarize, ASM guidelines we saw for recording and reporting arrhythmias, basic anatomy, we saw the conducting pathways, we saw basic ECG waveforms and their relation to the cardiac cycle. Also, we saw presentation of the normal ECG, presentation of the systematic way to analyze cardiac arrhythmias, examples of different arrhythmias like atrial, junctional, and ventricular arrhythmias, and AV blocks we saw. What are the interventions for serious arrhythmias? I told you, you have to call the emergency medical responses. And we also saw how do you record and monitor techniques and tips. Thank you. So if you have any doubts, you can email me and then I would be happy to answer your doubts.